Hey everyone, I am live on location in North Carolina at Vascular Solutions of North Carolina with Dr. Sid Rao. So excited to be here because my dad is here. He's having a couple of procedures done. I'm going to call it a revolutionary procedure for osteoarthritis in the hands. And Dr. Rao is one of the pioneers. I think you're the first one in the nation to have a center of excellence for these types of procedures.
Well, thanks, Kim. Thanks for getting me on the show. Well, I don't know if we are the first, but we are definitely amongst the first people to start doing this procedure. And like you said, it's pretty new. I'm not the founder of this. The godfather of this is obviously Dr. Okuno in Japan.
Right.
But we have I can say we have sort of perfected the technique now. It's a quick procedure. It acts at the root cause of the problem, which is all the inflammation around the bones, the synovitis. And people with arthritis who are suffering with hand pain can really benefit from this procedure if done early enough.
Yeah, let's talk about hand osteoarthritis. It's really painful. My dad, his hands were really swollen. He could barely move his hands. He couldn't open a jar. And it had been progressing over time, but then suddenly just recently, I've seen it becoming more prevalent where he would ask me to open the jar for him, or he can no longer take off his necklace. He wore a gold chain that my mom had gotten for him for years, and he was really sad when he thought he could not wear that necklace anymore because he could no longer do the hook or unhook it, and it was really disconcerting for him. So can you talk a little bit about this disease and what it does to these patients? What does it look like in their hands?
Yeah, so it's extraordinarily common. Along with the knee and the thumb joint are actually the two most common sites of osteoarthritis in the body. And you can imagine if you can't move your dominant hand, then activities of daily living are grossly impaired. You can't comb your hair, you can't open a bottle, like you said, you can't hold a cup of coffee.
No.
Things that you take for granted during your daily routine, you just can't do. You can't open the door of your car.
Mm-mm.
So simple things like that become an intense chore. So hand osteoarthritis is often under-recognized, under-treated. People say, "Oh, I'm getting old." So that's
Well,
probably
that's what
just
I
my.
thought. It wasn't until you actually, came on our show. My dad had no idea. He comes into my studio after the show and he said, You've got to be kidding. You mean this isn't just old age? You mean I can do something about this? I can use my hands again." And he
Yes,
says, "I'm going to North Carolina."
yes, yes, and that's the thing. It's often under-recognized, so it's under-treated, and people suffer needlessly for years and years and years. And while anti-inflammatories and physical therapy are great, they don't address the root cause of the problem as quickly as a transarterial embolization does.
So talk about the transarterial embolization, because you were mentioning, okay, so the osteoarthritis, it has inflammation that's in there, but there's something that has to feed the inflammation.
Correct.
And so walk us through what that looks like so people can visualize how this inflammation occurs, because we hear inflammation all the time. You get that blood marker checked when you go to the lab, you get your CRP checked, and people talk about this, you know inflammation. Help people visualize this.
Yeah, I think so far it's been very poorly understood. Osteoarthritis for years has always been thought to be years, decades, has always been thought
Yeah.
to be this degenerative problem. Oh, you have a little injury or you have a little overuse, and that just tends to progress in the form of chronic inflammation where you can't use your knee anymore, you can't walk without pain, or you can't walk, or you can't use your right hand. But there is more to the story. So, whatever the inciting damage is, whether it was overuse or trauma, it leads to this maladaptive response where your body grows these new abnormal blood
Yeah.
vessels whose only job is to perpetuate and propagate the inflammation. So that's why anti-inflammatories work, because they work on the end products of the inflammatory process, the mediators, but they don't treat the root cause, which is these new blood vessels that actually are promoting the inflammation. So with the transarterial embolization, that's how a vascular guy started treating orthopedic, so-called orthopedic issues. So we go in and actually kill off all those abnormal blood vessels and spare the normal ones. So this is one thing that I often get asked about. Say, oh, well, I mean, aren't you going to hurt the normal blood
Yeah.
vessels? The chance is very, very, very low if you know what you're doing. It's extraordinarily low. I mean, we're talking less than a percentage chance, 1% chance of anything bad happening.
How do you target those though? How do you say, okay, go where you need to go? Don't go here, don't go there.
Yeah. So while it is a minimally invasive procedure, what we do is we try to select the arteries that actually feed the affected joint. So, for instance, the thumb joint gets a branch from the radial artery that's close to the wrist.
Mhm.
So we predominantly try to target that little branch. So while there is some amount of non-selectivity, if I can use that word,
Mhm.
uh, to the injections, most of the particulates are taken up by these abnormal blood vessels. You have to understand these blood vessels are very avid. They want blood more than the regular blood vessels. So they preferentially draw all the particulates and thereby die off once they're clogged up.
And how long does something like this last? How long do they remain
Yeah, so that's
plugged
a
up?
great question. So I get asked that all the time. And the correct answer at the level of the hand is we don't know exactly. We know from studies of the knee that you can have pain relief for 2 years, if not longer, if not longer. So the truthful, the most data-driven statement is for the knee, 2 years if you've not had extensive damage of the knee. And I have every reason to suspect we are about getting ready to publish our 6 month data on our transarterial embolization of the hand series. And more than 70% of the patients have been completely pain free up to 6 months. So I have no reason to believe that it's not going to parallel the results that we've seen in the knees. Our oldest patient is now 14 months out from the last procedure, from her first procedure,
Mhm.
and she's still pain free,
Yeah,
completely pain free.
that's incredible.
She was a pianist, couldn't play the piano. Now she's playing everything, the piano.
Wow.
Yeah. So these are not isolated success stories. 70% of the time, these people have a new lease on life.
And I've heard you've had a couple golfers.
That's right. That's right. I'm single-handedly responsible for, no pun intended, for improving the golf scores of all these guys that come to my place.
So that's good for everybody to know. Here you've had people fly cross country for that.
Yeah.
Well, coming up next, right here on the Heart of Innovation, we're going to have more with Dr. Sid Rao. We're going to find out what fascinated him about getting into embolization for the knees, the hands, the shoulders, all of the above. Aside from just saving a life and limb, we'll get into that next. We'll also hear the results of my dad's procedures. So stay with us right here on the Heart of Innovation on KDOW.
How many procedures are you willing to go through? Is it worth going through that many, or would you rather just step
That's funny. Was it worth it? Oh yeah, I have my leg, man.
Amputation should absolutely, positively, 100% never be a first-line treatment.
What an incredible operation, what an incredible lab you have here. Without a doubt, we're underdiagnosing peripheral arterial disease. It has not gotten the attention that it should because it is a killing disease, it is a disabling disease, and most importantly, it's a disease that we now have great treatments for. Okay, let's go to the next one.
They were going to amputate it, and I needed to consult with my family. Did I want it off here or here? You're just shocked. It's scary. I don't even know how to explain it. You're 42 years old.
We're waiting till people are at the end of the spectrum and almost beyond hope. There is good care available here. Closed minds are what we have to get rid of.
Welcome back to the Heart of Innovation. Dr. John Phillips is off saving the piggies. I'm on location in North Carolina, Vascular Solutions of North Carolina with Dr. Sid Rao. We're talking about a newer type of procedure to help with osteoarthritis. It's called embolization. And the reason we're here is because my dad ended up having osteoarthritis in both hands and was having trouble getting his necklace off. He was having trouble opening jars. Just the daily chores, even opening up the glass door to go outside. He the day before we left, he puts the food out for the birds, and he couldn't get his hand around the door thing to just pull it. And he was so frustrated. There were some choice words. I said, what's wrong? What's wrong? He said, that Dr. Rao had better fix this.
Hope I don't disappoint.
No. And so far, so my dad had the procedure done, the first procedure done
Left hand.
yesterday. Can you walk us through when a patient, says, hey, you know what? My hands hurt. Walk us through the process, the initial consult. I know with my dad, we did a televisit because it was across country. You needed his x-rays. And then even when we were here and before we went into the procedure, you went through some protocols to make sure and test. Would you mind walking us through?
Yeah. So as we kind of talked about, transarterial embolization is predominantly for osteoarthritis. Yeah, whether it's at the level of the knee or the hand. And in some select cases, it can be used for chronic tendinitis too. So when it comes to hand pain, now this is not the treatment for all chronic hand pain. That's important to understand. So hand pain can come from a multitude of reasons, right? So the first step is establishing the right diagnosis. And the right diagnosis comes from a good history, good physical exam, and then x-rays. And the x-rays have to demonstrate osteoarthritis. If they don't demonstrate osteoarthritis, then this is not the procedure that's intended to relieve their hand pain. So that's what we did for Dad. We took a good history, made sure that we had his x-rays. We looked at the x-rays ourselves. We looked at the report, and they definitely suggested osteoarthritis. So that's the first step towards selecting the proper candidate for this procedure, Kym.
Okay, so he comes in and he of course gets the IV put in. It's light sedation just to relax you.
Yeah.
And you end up you have them squeeze your hand. What are some of the different
Yeah, so
exercises?
obviously we do a physical exam to test hand grip, to see how much pain there is with flexion, extension, abduction, adduction. So we want to assess range of motion and see how impaired it is before the procedure. And often, because the first thing that the procedure does is kill off the extra nerves that are also formed as part of this inflammatory cascade, patients have a lot of pain relief immediately after the procedure, and the range of motion increases by about 20 to 30%. Now, some cases are more dramatic, but on the whole, usually most of my patients, because we select them carefully, they're about 20 to 30% better already off the table. And then you've given the body some time to start healing without the constant barrage of those inflammatory mediators. And over the next 1 to 3 months, the joints start healing. So that's the usual course of the illness.
It was amazing. My dad comes into my room this morning and he says, look, I can actually bend my hand. I can close my hand. I can grip it. I was like, okay, slow down, slugger. Slow down. Let's just make sure we're not going to start grabbing things and whatever. That is a risk that you overdo it too soon.
Correct.
And you're feeling so good for the first time.
Yeah.
And it was the first night he has actually slept without any pain at all.
Yeah.
He was doing the Arnicare. He was putting some rubbing, what do you call it? The topical marijuana, every night.
Yeah.
So the funny part was when you first asked him, and I was there for the televisit, he first asks him, so, do you have any, pain at night or anything? My dad says, no, I'm fine. I was like, wait a minute. What are all those tubes sitting
creams and tubes? Yeah.
And he said, wait, what?
Yeah.
No, I think something more is going on here.
Yeah. So, it's since I'm a trained interventional cardiologist, I draw a parallel. I usually say patients, adapt to chronic pain like people adapt to aortic stenosis. They just slow down. They don't do things that normally they would have done if they didn't have the pain. So it's a similar sort of situation. People with hand osteoarthritis, especially the dominant hand, they stop doing so many things. Everything becomes a huge chore for them.
Mm-hmm.
So
And that's the way it was with my dad. But
Yeah.
you don't just jump right into doing this procedure. There's still,
Yeah.
well, a little bit that, there's a trend when you have physical therapy, you
Yeah.
have, anti-inflammatories, cortisone, things like that.
Yeah.
So talk to me about what a patient has to do before they get to this point where they can do a procedure.
Yeah, so typically we don't offer this as the first line of treatment. They need to have failed at least a couple of conservative modalities of treatment, like physical therapy and or pain medications and or steroid injections. So if they haven't responded to that, that's when we kind of, come in before surgery. So we position ourselves as sometimes as a bridge to surgery, or sometimes as an alternative to surgery, depending upon the stage of the illness. I mean, if the illness is too far gone out, if the joint is completely destroyed, yes, this is not going to be a permanent fix.
Right.
But the perfect candidate is those with mild to moderate arthritis with severe symptoms that are impairing their lifestyle. So that's the kind of patient we put on the table.
Yeah. We'll come up next right here on The Heart of Innovation. We'll have more with Dr. Sid Rao. So stay with us. We're going to find out actually what sparked his interest in this. I know I teased you on the last one, but we're going to get to it next, I promise. So stay with us right here on The Heart of Innovation on KDOW. Don't go away.
Your type of condition is called critical limb ischemia. It's the most advanced form of PAD or peripheral arterial disease.
Every 4 minutes, there is an amputation in this country due to PAD and diabetes. We also know that 85% of these amputations are preventable with early intervention.
It's a flip of the coin. Patient prognosis is tied to whether or not they are referred to a true expert in the management of peripheral arterial disease.
Do you know if your physician is an experienced CLI operator?
When you're in the hospital dealing with doctors and stuff, you figure they know what they're talking about.
The skill level varies doctor from doctor and hospital to hospital.
Patients with limb threat are in constant fear. The depression that someone experiences after they lose a limb is equivalent to those of losing their spouse of 40 years.
I was stuck in a wheelchair close to 2 years and my husband had to quit work.
I didn't know what to do at this point because we had had nothing but infections and hospital stays and infections and hospital stays.
And they took one toe, another toe, and then it was another toe, and then half his foot before he was even diagnosed with PAD.
And all I heard was, "What are we doing here? Just cut it off." And I pulled the curtain back like, "Are you kidding me?"
Do you really want to go through all that?
That's crazy. That's insane.
The protocol is to send them to amputation. Always, always, always get multiple opinions.
We do have options.
We need to listen more to our patients.
If you're going to chop off their leg anyway, why not just let someone else try?
This is the progression. First comes the wounds, and then comes an amputation. And I wasn't going to accept that.
So that's what it's like to try to save a leg.
Hi, everyone. Welcome back to the Heart of Innovation on KDOW. I am on location at Vascular Solutions of North Carolina while Dr. John Phillips off saving some piggies somewhere in Ohio. He always is saving life and limb. But here we have Dr. Rao, who just saved my dad's limbs. He's been in so much pain for I don't even know how long. I mean, even before he started complaining about it, once he learned that there was something that someone could do about his hand osteoarthritis to give him his function back, give him his quality of life back, allow him to get some sleep at night, even just open a jar, fix his necklace. He was like, we're going to North Carolina. We are going to do this. We're going to get this new embolization procedure. We've been talking that he just got the first procedure yesterday. He is already seeing great functionality changes. And then today, talk us through, you just did the other hand, and I haven't heard anything about this yet. So tell me about the second hand. He was in and out. I mean, no joke, within just a few minutes. I think it was less than 5 minutes. I was shocked.
So so the procedure itself is very minimally invasive. All it takes is a small needle puncture at the level of the wrist, and usually skin to skin, as we call it, is under 7 minutes, I would say. The recovery is actually longer than the procedure itself, because we have to make sure that the spot that we punctured in the artery kind of starts healing off and it doesn't bleed, so we send patients home safely. But one of the things you were asking me is, how did I, an interventional cardiologist, get into this stuff? So the story is a little long, so I'll try to be brief. But I did do an extra year.
Time.
I did do an extra year of endovascular fellowship after my interventional cardiology fellowship, and like most people who do endovascular interventions and start taking care of peripheral arterial disease patients, I did that for more than a decade. So almost about 15 years of endovascular therapy. I was the first one to start a critical limb ischemia program here in the Raleigh area at one of the Wakeman hospitals. And over the years, thousands of interventions. The one thing I noticed is the best medicine is to make people walk, right?
Yeah.
We always say this. Few things work as well as walking every day. So one of the things I noticed is I could take care of patients' claudication. I could take care of patients' wounds, help heal them up with the appropriate endovascular therapy.
And we're talking about the peripheral artery disease. If you've tuned into this show before, we talk a lot about peripheral artery disease. It's that poor circulation in the leg arteries that left untreated can lead to amputation. So you got to walk, and walk even more to grow your collateral vessels. And if that is not improving your symptoms, it's not helping you get some sleep at night, not helping you walk further or heal any wounds that develop on your feet, then you have an endovascular procedure where they may do a little angioplasty, dilate a balloon, push the plaque aside, a little roto-rooting is possible, maybe a stent, but that's really what you were into before. Right. But with these patients, you still notice that some of them still could not walk because these procedures, they're not durable to open up the arteries. So you need to walk. The only reason to have these procedures is that you need just enough blood flow to get you walking so you can grow your natural bypasses. But these patients, who are these patients that
so the end goal of therapy is to heal their wounds, take away their pain so they can walk. And what I noticed, a lot of these patients still couldn't walk because of arthritis. So in a way, I felt like I had failed them because sure, I took care of the muscle pain and I took care of the wounds, but they still can't walk because their knees hurt. And that's when I started looking up the data for, what is new here. And it's remarkable. No other field in the last 40 or 50 years has changed this little. Everybody with arthritis has always been treated with pain medications, physical therapy, intraarticular steroid injections, or some other injection, a different flavor. And then when ultimately all else fails, you end up getting your knee replaced. But guess what? From the initial anti-inflammatory to knee replacement, there's a decade of suffering there.
Yeah.
Right? There's a decade of suffering. So transarterial embolization breaks that time of suffering. So when I saw that there was something new on the horizon, I started, reviewing the literature. There's this story that my wife likes to tell. On a Friday evening, she says, "Hey, is it movie night? What are we guys doing today?" And I said, "I don't know what you guys are doing." That's my wife and my son. I said, "But I'm going to lock myself up in my office because I got to review some literature." That's what you're going to do on a Friday evening? And I said, yes. So about 3.5 years ago, about 3.5 years ago, I locked myself up in the office. And by that time, there were already about 17 or 18 studies published. And I just devoured those studies, slept, read through the night, slept a little, got up in the morning before the family's up, got my cup of coffee, finished reading those studies. And I told my wife, this is legit. This is legit. This is a legitimate field. It's backed by tons and tons of data. CMS has approved this procedure. There's no reason I can't get good at this.
So coming up next, right here on the Heart of Innovation, we're going to find out how he got good at that next. So stay with us right here on the Heart of Innovation on KDOW. Don't go away.
Well, I'll tell you, there was a case of a woman in her 40s, a nurse without diabetes, actually, who came in with a wound that didn't heal on her foot, and had seen a variety of different doctors, and not one of them had even considered peripheral artery disease. We have in our minds, this is the kind of patient who has it, and this isn't who doesn't, and I think it's underappreciated. So, unfortunately, by the time she got to us, her disease had progressed and she required an amputation. And there was such a missed opportunity there. If people had just said a non-healing wound on somebody's foot, we have to think about vascular disease. No one's immune. And even though, there are higher risks in different groups, we have to check, feel the pulse in the feet, order the ankle brachial index, and figure it out, because you can prevent amputation.
Welcome back to the show, everyone. We are live at Vascular Solutions of North Carolina. Well, Dr. John Phillips is in Ohio, so we're saving those piggies. But the reason I'm here, if you've been tuned in this entire time, is my dad had a procedure, well, two procedures, one on each hand for his osteoarthritis. And we're still going to hear exactly how he's doing. Maybe we'll check in with him before we go into the last segment and see if he can move his other hand, because he's in recovery right now. But before the break, I was really excited. So you started learning that this was a potential for the knees. For your patients who have peripheral artery disease that need to walk, you restore the blood flow, but they're still not walking because they have knee pain. And many of them, especially the diabetics, may not be surgical candidates. So they may never be one that could be a candidate for knee replacement. And so they can't walk. They're not mobile. What happens? They lose their limbs and they lose their life.
Correct. So again, it comes back to this core tenet of treatment, which is you got to make people walk. Doesn't matter how, you got to make them walk, whether it's restoring their blood flow, healing their wounds, or treating their knee pain. And like we were talking about, how I got into this, once I reviewed the literature, I was convinced that this was legitimate. And so I had one of my friends come up and proctor me for the first couple of cases about 4 years ago. And he said, "Man, you don't need my help. You're good." And he got an early flight back and went home. So that's how we started.
Confidence building.
Yeah. So that was actually pretty cool. So that was about 1,000 cases or more, actually. So we do about 500 of these every year now, and we have the most experience doing this now from the foot. That's one thing we have pioneered, doing this embolization procedure from the foot. So what I realized is all these people that couldn't walk, now a lot of them began to walk. And we have such incredible patient stories, incredible stories. We had a former WNBA athlete who developed arthritis because of all the jumping, and she put on weight, and she put on so much weight that none of the surgeons would do bariatric surgery on her. So she had moderately advanced arthritis in both knees. I embolized one knee. I don't know how she found me, but she found me, and I embolized one knee. And she came back for the other knee a month later, and she had lost 30 pounds.
That's amazing.
I mean, the first thing she did was hug me, saying, "Oh my God, I'm pain-free for the first time in more than a decade in my knee." And she had tried everything under the sun, right? Everything. Every steroid injection, every joint injection that you could think of, physical therapy, pain medications, nothing had worked. And obviously, because of her body habits now, she had put on so much weight, no orthopedic surgeon wanted to touch her. How do you tell a 50-year-old that that's her life? How do you tell that to a patient? Say, this is your life. This is it. You're done.
But they're doing that all the time. I mean, they're still doing that in many places that don't know that this potential procedure that is minimally invasive. You were saying that it's not just so before what they were doing originally is poking into the groin area, an access point right into the artery to send the catheters and such down to the knee. Now you're saying you can actually go in an even less minimally, even more minimally invasive way in the foot. So you're not worried about the additional complications that may arise with a groin access point.
That's right. So the most common complication in the clinical trials for this procedure was about a 5 to 7% chance of groin bleeds. Now, in my mind, that's a pretty high complication rate to to have in a patient who walks in, who otherwise isn't metabolically sick.
Yeah.
And doesn't need a high risk procedure. So because of my experience in doing endovascular interventions from the foot, I said, well, why can't we do it from the foot? I'll tell you, the first 20 cases, my team hated me because they took so long, because there was no equipment built to do this from the foot.
Yeah.
But as we got better, we figured out our algorithm, the equipment. I mean, now it's a 45-minute procedure at the most, as short as 20 to 25 minutes. Most of the time, on average, about 30 minutes for the procedure, skin to skin, 45 minutes of recovery. And remember, we are an outpatient facility here, Kym. I don't have the ability to admit somebody overnight here.
No.
But we have done over 700 patients from the foot now. Everybody's gone home. Everybody has gone home safely.
That's incredible. And you don't have to worry about those hematomas.
No.
You have the bleeds up time, and that's really good.
Yeah, we've had patients drive up from the DC area. We've had patients come up from Charleston, people flying from Florida. I seem
California.
I seem to have an in with the people in California. One of my cousins is a venture capitalist there, and he has had all his friends. These are all high-powered executives who don't want to be out for 3 months. And they come in, they fly in the night before, and then they get the procedure and leave the night after, and they're doing great. So to ensure that extra layer of safety in people who are flying back 3,000 miles, I have to make sure I do everything to keep this ultra safe. And doing it from the foot is the absolute safest way to do it.
And you're working in closely with orthopedic surgeons, so they're
Correct.
not looking at you as being competition.
No,
they're looking
no.
at you as, in a sense, adjunctive therapy.
Yeah.
Because why wouldn't they be able to do it? Well, it takes probably a little bit more training to be able to get to this, right? A decade. I mean, you already know how to navigate the boat through the arteries.
Exactly. So, and again, this is important to understand, right? We are not competition for the orthopedic surgeons. We work with them collaboratively. There are many patients that embolization doesn't work. I mean, advanced arthritis completely destroyed knee joint. No, this is not going to work as a long-term fix. So, but for the patients who are not the greatest surgical candidates, who are too early for surgery, who've had post-knee arthroplasty pain, most people don't know this. They say, well, you know what, I'll just get my knee replaced. 80% of the time, they have a new lease on life after 3 months of intense PT. 20% of the time, 20% of the time, they're still living in pain 1 year after surgery.
Still, the inflammation's there.
Well, you've taken care of the bone-on-bone pain,
Yeah.
but guess what? You haven't taken care of the synovitis.
Yeah.
And now you have this huge foreign body in there that incites a foreign body reaction. And so I tell orthopedic surgeons, say, hey, those patients, they're your toughest patients. So if they haven't responded to whatever you're doing, send them to me. I'll take care of them. And now we have the world's, if not the world's largest, one of the world's largest data sets for post-knee arthroplasty pain. The use of genicular artery embolization in those patients. So we have a lot of experience. And even those patients in whom we can't see the genicular arteries that are hidden behind the metal prosthesis, we still do it from the foot.
So it's interesting because you're an interventional cardiologist, and most of the time we're seeing this being done in interventional radiology.
That's right.
But now we're also seeing some vascular surgeons get
Correct.
into this.
Correct.
I almost imagine that there could be come a turf war where orthopedic surgeons go,
Well, the great thing is, Kym, I'm too old to care about all these politics. We are patient centric in our approach, and we that is our mantra. We stick to it. This is patient centric care. I do training courses for a lot of physicians from across the country. At least twice a month, we have training courses, and I have trained interventional cardiologists. I've trained interventional radiologists. I've trained vascular surgeons. I'll train anybody that has good catheter skills in the FEMPOP territory. This is not rocket science. It can be learned through good proctoring. I'm always their backup when they start to do cases. We send proctors out to help them with their first. Yeah, this is a very structured training program. It's not a fellowship, but it's a very structured training program where the focus is on getting that physician and their team up to par with our skill set, right? So there are more than 30 million people living with arthritic knee.
Yeah.
all these turf wars that you saw for peripheral arterial disease, or you see for peripheral arterial disease, are for about 5 to 6 million patients. There's so many patients living with chronic pain that there is a need. There is a dire need for people with skills that can help them. I can't help everybody in the country.
No.
Right? I mean, people can fly in from California, but they can't, not everybody can come to my place, right? So it is, I feel it's a moral prerogative now for me to pick good physicians and train them well so that they can help the patients in their community.
And coming up next, right here on the Heart of Innovation, our final segment, we're going to get some final thoughts from Dr. Rao. And he might even offer some critical questions that you can ask to choose the right doctor for you who performs these procedures, and how to decide with that doctor whether the procedure is right for you. Also, we'll get that final update on my dad. So stay with us right here on the Heart of Innovation on KDOW. Don't go away.
When your sugar runs high, it's more than a sign. Diabetes creeping in, it's a dangerous line. Pre-diabetes too, don't think it's too light. It can lead to PATS, so start the fight. Sugar's sweet, but the cost is real. High blood sugar makes your arteries feel clogged. Slow flow, it's a ticking time bomb. Catch it early, stay strong, and keep your legs on. Sugar's not so sweet when your leg is in pain. Not controlling sugar is where peripheral artery disease sets in. Got sugar? Get checked. Don't wait too late. Save your legs, save your life. Take control of your fate. Leg pain, cold feet, neuropathy too. These are signs diabetes caught you. High sugar's the link where circulation and pain left untreated. Your leg might end inflamed.
Welcome back, everyone. This is the final stretch here, and I'm with Dr. Sid Rao. He just went out to go check on my dad following his second procedure. He had the first one done on one hand yesterday. He had the right hand done today. Tell us how he's doing.
Yeah, he almost crushed my fingers. So I kind of told him I needed those for my subsequent patients. So now he's doing great. So no pain on flexion, extension, adduction, adduction. So good range of motion, great hand grip. The site looks good. There's no bleeding or anything like that. They already have the bandage on, and he said he's ready for breakfast.
Yes, there is great food. I'm going to tell you, great food here in North Carolina. And so if you come here and you get a procedure done, make sure you not only go to the famous Toastery for breakfast, but to go to Saffron for dinner. I'm just going to give them the plug because it was delicious. The kale and spinach appetizer was unreal.
Yeah.
And they know exactly who you are.
That's right. I've been there long enough.
So for those
that
can't make it to North Carolina, hopefully maybe a few can, because we came all the way from California to make sure that you want the best, right? We couldn't go to Japan, so I'm just kidding. But what does a patient need to know in choosing a doctor for one of these types of procedures? Because you definitely don't want to be the test bunny.
Yeah. So, you don't take your Mercedes to Jiffy Lube when there's a problem with the engine, right? So that's what I tell patients. Pick your physician well. They need to have been doing this for a while. They need to have had multiple hundreds of patients experience under their belt. And this also kind of is a good segue for why I'm doing what I'm doing, because there's just too many patients and there's not enough physicians trained. There is not a fellowship program in the country that can churn out physicians with the skill fast enough. And that's why twice a month, sometimes 3 times a month, depending upon how hard my center director wants to work me, I do training courses for physicians. And I encourage all interventional cardiologists, interventional radiologists, and vascular surgeons who live in the FEMPOP territory in the PAD world to come and learn this, because you can definitely help your patients.
Oh, it's so important. I mean, walking is the best medicine. Yeah. We've said it during this program. You lose mobility and you lose limb and you lose life.
Yeah, you don't walk, you die sooner, unfortunately.
What's that one story that stands out for you that makes you it drives you every day? You think about it a lot more than you ever thought you would, but it's inspiring.
So we've had so many success stories now, Kim, but I think the story of this retired WNBA athlete from recent times really sticks out. I mean, this lady lost 30 pounds after her first knee embolization. Came in the first time she walked in with a cane. The second time she walked in for her other knee, she came in without a cane.
That's incredible.
And like I said, as soon as she saw me the second time, she hugged me. I mean, she had tears in her eyes saying, wow, you're helping me walk again. You know, simple thing like walking to the bathroom was an impossible task for her. And now she's able to do everything. So we've had innumerable stories like this. We've had guys with golf swings and golf scores that have improved. We've had 67-year-olds who can play doubles tennis. They had played tennis for 40 years and couldn't play doubles tennis anymore. And they're playing tennis for a couple of hours every day now. So overall, I think mobility, doing this is important because restoring mobility restores health.
Great way. And thank you so much.